Thank you. Like she said, my name is Stephen Couch. I specialize in eye plastic surgery. So most of you, or many people, don't actually know that that's actually a subspecialty, but within St. Louis, there's 4 of us that do what I do. And I specialize in eyelid and eye socket and tear duct surgery. So today they asked me to talk to you guys about tearing after head and neck cancer, specifically after thyroid cancer. So I have a fairly global overview, including some surgical photos, intraoperative surgical photos, so I thought I'd kind of enlighten you guys. Basically, I'm a plumber when it comes to the tearing system, because the ideal, actually the eye has a lot of fluidics, has a lot of plumbing type of issues, and specifically the tear duct is all about plumbing. And so I have no disclosures. We're going to talk about the anatomy, the history, how we evaluate tearing, causes for tearing, especially after in this setting, and then the treatment. The treatment comes in kind of 4 major forms. It can either be troubles at certain ends of the tear duct, or it can be troubles in the actual plumbing or the tubing within the tear duct. We're going to go through this slide, and this is something that every single tearing patient that I see, I actually draw something similar. I probably should just print it off, and that way I just hand it to people, but it's easier if I draw. But the tear duct, or the tear system, basically has a faucet and a drain. Okay, so we've got our faucet, which is our tear gland, in the upper outer corner of our eye. That produces tears that roll across our eyes and in these little tiny holes. These little tiny holes are called puncta. They're right here. If you look, you've got one on your upper and your lower eyelid. They lead into tubes, and these tubes are about 1/4 millimeter thick, diameter. And those tubes are called canaliculi. And these canaliculi join up into a common canaliculus and drains into a sac way down deep in the corner of our eye, down far enough to typically where you can't feel it. That sac then drains through bone and down into your nose. And that's actually one of the reasons that your nose runs when you cry. So when and I'll say this a few times, but whenever I assess people that have tearing, the question is the problem with the drain, is their eye dripping or is their eye tearing because there's problems with the drain, or is there problems with the tear gland to where the faucet's on too high, if you will? Okay? The inside corner of the eye is probably one of the most complex structures in the entire face. And so that's why any trauma or anything that happens in there, typically somebody like myself gets involved, because there's multiple layers of muscles and tendons that surround that tear system. And your entire tear system is not only surrounded by tendons and nerves and muscles, but it's actually surrounded by some of the certain layers of skin that help to pump tears from your eye to your nose. Again, looking at this inside corner, we've got about 5 different tendons in the upper and 5 different types of tendons in the lower that control the tear pump and protect the tear system around the eye. It's not that there's just an open hole and an open drain that your tears flow into. There's actually an active pumping mechanism. And so when the eye moves and closes, it actually creates negative and positive pressures within that tube that then force the tears down the eye. So, for example, here, the eye is tears, patient is blinking. The blinking then causes positive pressure through that tear system and then pumps it down into the nose. And you have to have active blink, and you have to have good muscle tone around the eye in order for that tear pump to actually work. Like I said, the tear duct itself is about 1.5 millimeters in diameter in most patients, and it pierces through bone. So when babies are developing in utero, that is one of the last things to open, and that's why many kids, whenever they're born, are born without a tear duct that works well, because as it's entering the nose, there's usually a little membrane over the top of that has to open. Actually, my second daughter had to have that done. It comes out in a very specific place within the nose. Within your nose, you've got these things called turbinates, and these turbinates are basically wind tunnels inside of your nose that help to humidify your air when you breathe through your nose. And these turbinates are responsible for, underneath the turbinates is where the certain sinuses and the tear duct drain. The only thing that drains into the floor of the nose is the tear duct. Everything else drains a little higher within the nose. Again, complex slide, but basically it's just saying that there are lots of things that empty into your nose, but there's only one thing that really empties into the bottom part or the floor of your nose, and that's your tear duct. Everything else is higher. When I see somebody that comes in for the concern of tearing, my question is, and what I'm trying to assess, and I teach residents every week or every day, and I teach I teach ENT and ophthalmology and plastic surgery residents every day. And when I see somebody that has tearing, the basic thing that I'm trying to understand is their eye watery or is it tearing? Because in my mind, those are different things, and we're going to talk about that. How long has it been going on? How often does it occur? When does it happen? Is there anything that makes it better, anything that makes it worse? Does the patient have any significant irritation in their eyes? Do they have a lot of troubles with bright lights? And then I specifically ask, and believe it or not, one of the things that I look in their medical history is, do they have a history of thyroid cancer? Because, and we'll talk about this later, but radioactive iodine is highly associated with a blockage of the tear duct in my practice. Low incidence, but high association in my practice. Watering. Watering eyes are eyes that intermittently start to fill up. Typically, a person will say that their eye fills up with water, their vision gets a little bit blurry, they have a little sandy sensation in their eye, they maybe have a little bit of a gritty or troubles with redness. It's usually associated with tasks, meaning that they're reading, they're watching TV, they're using the computer, doing things like that where there's episodes of prolonged staring. So somebody that, as you know, when you read a book, even if you're not totally engrossed in the book, you tend to stare. You don't blink as often. And actually, a watery eye, in my mind, is actually a dry eye. And we're going to talk a little bit about that. A tearing eye is one that is constant. Patients say, I can't do anything without a tearing. It's always dripping down my face. It's not that it just fills up in the eye, it actually drips down their face. Maybe mucus discharge. They may have a history where I saw a guy yesterday, actually. I did 2 of these surgeries today, but I saw a guy yesterday that he said that he gets a big lump in the inside corner of his eye, and he pushes on his tear sac, and pus comes out. And he does that every day, but he's been doing it since 1971, which is why. But anyway, so they may say that they're, and typically somebody that has a tearing eye is more likely to have it worse on one side than the other. People that have a watery eye or a dry eye, usually it's pretty much both sides fairly equal. Here's a guy with a red, itchy, scratchy eye that says his eyes water. This is a person that has a tear that is totally full. I mean, that eye is completely full of tears. Difference. So when I look at patients, I look at their eyelid position, upper and lower eyelid. Many patients don't know that I consider this your lower eyelid right here. This is your upper eyelid, this is your lower eyelid. Some people call it an under eye. Different people have different terms. There actually is a junction of the skin between your eyelid and your cheek. So as the thinner skin of the eyelid becomes the cheek, there's a fairly pronounced junction in many patients. I look at how well their eyelid works. I look at the muscle tone, the closure. Can they close all the way? Is their eyelid up against their eyeball? Are those puncta in the right position? I look at their eyelashes. Is there any eyelashes that could be in there poking the eye? I look for facial nerve functioning, their blink, and then I push. And it feels weird, but I kind of go deep down in the corner, and it distorts your eye, but I push down in there and see if I can feel anything where the tear sac is. both these patients, this one has a little bit of fullness right here, but this one has an obvious amount of fullness right here. If I push on their tear ducts, a little tough to see, but that's a pretty good amount of mucus that came out. That is a full tear duct. That is a blocked tear duct. One of the cool things about being an eye doctor is that we have lots of fancy toys. So one of the things that we use is this thing called a slit lamp. The slit lamp is a three-dimensional microscope that allows us to view living tissue, that's not common in medicine, actually. It allows us to assess how much tears they have. Do they have mucus? Do they have filaments or different aspects within their tears? It allows us to look at the size of those puncta. Are they in good position? It also allows us to look at the conjunctiva, or the skin covering around the eye, and the cornea, which is the center part of the eye, where it has that's where just in front of the colored part of the eye. And then I actually spend time watching people blink underneath this, because again, I'm trying to assess their tear pump. When we look through this slit lamp, this is similar to what we see. This is a three-dimensional. You can see that the light has a dimension to it that allows us to assess depth and also things within anything that could be going on within the depth of somebody's eye. One of the big things that I do is testing for people that have tearing. If I just drop a dye in your eye and I walk out of the room and then I come back, let's say I put it in both eyes and one eye's full of the dye still and the other one's not, that's a pretty good indicator. It's not highly specific or sensitive, but it's pretty specific. You can also do testing, which I actually don't do, where you can take cotton swabs and you can stick it up in people's nose and see if you collect the dye. I don't know that that's really that helpful. Or you can irrigate the tear duct and see if the dye comes through. Really what I rely on, this is the dye disappearance test. This is just collecting it in the nose. And then this is irrigating and collecting it in the nose. So this is a guy that I put dye in his eye. And the right side is totally full and it's dripping down his face. The left side's normal, or still has some in there, which is normal. Really, this is the mainstay of how I interact with patients that have tearing. This is called nasal lacrimal irrigation. So I tell patients, whenever I see a patient, I tell them that I describe the faucet and the drain, and then I tell them that I would like to use a syringe and squirt fluid into their tear duct. And I tell them it looks like a needle, because that looks like a needle. But it's not. It's not sharp. It simply goes in the tear duct to squirt fluid in there. And then it allows me to assess if there's blockages or narrowing, where exactly those blockages or narrowing is. I use tap water. I visualize the opening of the puncta, and then I just simply stick the cannula down in there and squirt fluid. So here's our diagram. So we've got our eye, we've got our upper and lower puncta that lead into these canaliculi, common canaliculus, into the sac and down into our nose. I use this little dilator to dilate the tear duct, and then I squirt fluid in there. Now, when I squirt that fluid in there, in the ideal world, that fluid just goes through and down into the nose, and people kind of feel like maybe you sniffed water whenever you were in the swimming pool. If there is obstructions in people's tear ducts, I usually am able to tell based off of this irrigation. Either A, I'm not able to put the irrigation cannula into the tear duct, or B, when I squirt the fluid, it comes out in certain patterns. So if I go into the canaliculus of the tear duct, that's just the narrow tube, and I squirt fluid, and it comes right back out the tube, the same way that I'm going in, like this, that's an obstruction of the canaliculus. And we're going to talk about this, but that requires a specific kind of treatment. That's as opposed to what we call an NLDO, nasal lacrimal duct obstruction. If somebody has a narrowing of their tear duct and I squirt fluid in there, that fluid will come out of the upper eyelid and also through the nose. Versus if somebody has a complete blockage of their tear duct, I squirt the fluid in there, and it only comes out of the upper eyelid. Or if I'm going in the upper eyelid, it comes out of the lower eyelid. And when we do that, a lot of times we get mucus because that tear duct is totally blocked and it collects mucus. We're going to start talking about some of the causes for people that tear, especially in the setting of thyroid cancer and head and neck cancer. I'd say half of the patients that I see for the diagnosis of tearing or watering eyes are actually watering eyes, in the sense that both eyes, a little bit of redness, little gritty sensation, worse with certain activities. And the way I consider that is I consider that to be a tear overproduction, or I consider that to be the faucet, if you will, is on too high. It's a common, one of the questions is, how in the world can a dry eye cause tearing? Okay? And the reality is, what happens is that the eye has some very important nerves that are associated with the front surface of the eye. If you have tiny little dry spots on that front surface of your eye, the body's response to it is to shower the eye with tears. So the eye says, hey, we're dry, let's overproduce some tears, and the eye gets watery. So that's how and it's always crazy whenever I tell patients that have a watery, dry eye or tear overproduction. When I tell them to put drops in their tearing eye, they look at me like I'm nuts. And in all honesty, the drops don't work if the eye is dripping. The drops work as a prevention to keep the eye from dripping. So if you can do it, put a drop in there, and trick your body into thinking it's not dry, then many times that tearing won't happen. You can also have disturbances of the lacrimal gland, you can also, or facial nerve dysfunction, or incomplete closure of the eye. Right around a quarter of patients that are treated with high-dose radioactive iodine will develop dry eye. And that's because the radioactive iodine actually accumulates within the tear glands. The tear glands then don't produce as many tears, and believe it or not, the tear film itself is a fairly complex milieu. It has a lipid layer, it has a water layer, and a mucus layer. And if there's some alteration in that balance, the eye becomes teary. Patients will describe irritated, tired eyes, especially towards the end of the day. Usually it's both eyes, and describe blurry vision. When I look at patients, basically they'll say that their eye is tearing, and I look in there and the eye is bone dry. And I always ask patients whenever I'm seeing them, well, do you feel like it's tearing right now? And the majority of these patients will say yes. And that's when I'm able to tell them, I don't think it's your tear duct. You can have, this is a stain that only normally is very clear, but you can see all these little spots here, and those little spots are all little spots of dryness. This looks, it looks like the Sahara Desert. It is very dry, and it's a very dry eye. The treatment, the cornerstone is drops, so lubrication. If you walk down the artificial tear aisle at Walgreens, it's like walking down the toothpaste aisle, right? There's so many brands, types, flavors, whatever you want to say about it. And in all honesty, not one of them has been proven to be better than the other. I generally tell patients to avoid the ones that say get the red out, so like Clear Eyes or Visine. But after that, it's dealer's choice. And in most patients, it takes several different trials of them in order to get to know which one works the best. They generally come in mild, moderate, and severe. And then they also, another distinction point is, and the more severe you get, the thicker the drop, because it needs to stay around in your eye a lot longer. The other distinction is whether there's preservatives. The drops that come in big, giant bottles, well, what we consider giant, bottles have preservatives in it because that allows you to open it and then keep it for 30 days. Versus there are non-preserved drops which have nothing in them to irritate or cause discomfort within the eye. And those drops are usually in a box and they come in individual packets. The way I tell patients to use those is to take off one packet, open it up, put a drop in each eye, and then the company doesn't want you to do this, but put the cap back on, and you can keep it for a day, and typically that's all most patients need. If patients are using it more than 3 to 4 times per day, you almost want to make sure you put the drop in. You almost want a non-preserved tear so that it's not going to irritate the eye. You can also block the tear duct. So we can do things that actually block people's tear duct. And if you block somebody's tear duct, it's like putting a stopper in the drain. And if you block that tear duct, then it allows the water level in the eye to actually raise. Occasionally somebody will put little stoppers in the tear drain, and those stoppers come out, and we do things that cause scarring over the tear duct to allow it to be permanent. Other medications, things like Restasis, topical steroids, and other things like that are used in some cases. Restasis, they want you to believe that it's the cure-all. In my practice, it's not. But in some patients, it does seem to work well. It certainly does a good job of draining your bank account. Occasionally, patients that have any form of radiation or have had chemotherapy will develop a facial palsy. If you have a palsy to the nerve that controls all the movement of your face, one of the big complications is troubles with the eye, because the eye doesn't close very well. So you can see on this gentleman, this eye is, the right lower eyelid is a little bit lower, and then when he tries to close, the eye just simply doesn't close. Patients that tear, that have a facial palsy, it is so complex why they tear, but it can be because of dryness, because they can't close their eye. Their tear pump doesn't work. Occasionally they'll have a nerve that will regenerate, and when they're chewing or doing things, that nerve will stimulate the eye to produce a bunch of tears. And then eyelids being abnormally in an abnormal position can cause it as well. When we see these patients, we have to do things like implant weights and surgically correct their eyelids so that they can close and so they can improve their eyelid functioning. In some patients, those little puncta are gone. For whatever reason, they're either scarred or you can't see them. And in that scenario, what you have to do is you have to open it. Now, that can be done by just making a small snip, but I typically, in my patients, actually take them to the operating room, make a small snip, and then I put tear duct tubes in there. And those tubes stay in the tear duct for about a month to 6 weeks, and it'll just kind of naturally stretch it open. When I do that, I actually put put the tube in the tear duct, and that allows that tear duct to actually stay open, and I retrieve it in the nose. Specifically, there are chemotherapy agents that can cause obstruction of the canaliculus and those little tubes. The big one is one called Taxotere, which is kind of a funny name because it causes tearing. But if when we irrigate somebody's tear duct, we actually notice that you can't get the cannula in, or you irrigate and it comes directly out of the same cannula or the same canaliculus. Then what you have to do is you have to surgically open those tear ducts and put tubes in them. And in some cases, you have to do a very drastic surgery if it's too far advanced. Specifically, docetaxel or Taxotere can be highly associated, and it can be used as an adjuvant for patients that have cancer, even thyroid cancer. When this happens, what it does is it collects within those canaliculi and it causes progressive scarring. If you catch it early, you're usually able to make it better. Late stages require a pretty drastic bypass type of procedure for the tear system. This is the one that I most commonly associate with patients that have thyroid cancer. Nasal lacrimal duct obstruction, or NLDO. These tubes that go into the nose are very narrow. And those tubes are 1.5 millimeters or less narrow, and they go directly through bone. If you get a blockage in that tube, the tears will collect in that sac, and then the eye just won't drain itself, and it'll just constantly drip. mucus, or even infections. In some patients, it can actually just be a narrowing of that tear duct. If it's 1.5 millimeters, it may be a third of a millimeter, or maybe a half millimeter. And in that scenario, patients can complain of constant or intermittent tearing. And one way to treat this is actually with a balloon dilation procedure, where you can stick a balloon that's similar to an angioplasty balloon into the tear duct and dilate it. My experience with that is it works right around 60% of the time. So it's not a super effective procedure, but it does seem to work in some cases. Complete or full blockage of the tear duct. Patients will complain of constant daily tearing, mucus discharge. They may have an infection. This is an obvious infection in that tear duct. This is a small infection, and this is just a lump. If we push on that tear duct, we should get pus out. And if it's an active infection, what I typically do is I'll drain that through the skin. I'll actually drain the tear duct and try to get the mucus out of there and put people on antibiotics. If you do surgery on somebody that has a blockage of their tear duct, you want to do it when they're not infected. So we treat people's infections, and then we bring them back to do a procedure on them. Just because you have a blockage of your tear duct, a complete blockage, does not mean you have to have any procedure or any surgery to make it better. So not every patient that I see decides to have surgery. I generally tell people that at a rate around 5% a year, somebody with a complete blockage of their tear duct will develop one of these infections. If you have no history of an infection, it's not hurting your eye to have a tear. If you do have a history of an infection, I strongly encourage my patients to have it, because these infections can actually be vision-threatening in severe cases. So, complete blockage of the tear duct, no history of infection, you can leave it if you need to. It can be due to a microinfection. We'll talk about the radioactive iodine. You can have it from broken nose or sinus surgery or nose surgery. If you do anything in the nose, it's such a thin tube, it can actually be blocked off by that. Like I said, when I drain these, it just get a fountain of pus in a lot of cases. Put people on antibiotics, and then I eventually do a procedure to make them better. This is a CAT scan or a CT scan, and this is cut like this, so that this is the right eye, this is the left eye, brain, nose, mouth. These are those turbinates. And you can see the tear duct as it comes down into the nose is blocked right here, and it's creating a large cyst and an infection right there near that patient's left eye. So radioactive iodine has been used since the 1940s, and it's used in lots of different thyroid-related conditions. It can be used in the treatment of cancer. I am not a thyroid cancer specialist, so I just know what the literature tells me. But I can tell you that I also see a lot of patients that have a similar condition called thyroid-related ophthalmopathy, or thyroid-related eye disease. That is a different subset of patients, but it also can be, the eyes can be stimulated and worsened with radioactive iodine as well. And that's for the treatment of patients that have Graves. It does seem to be a cumulative thing. So if a patient receives radioactive iodine and they have to have it again and again and again, each dose is cumulative and raises their chances of developing a tear duct blockage. The risk factors are mostly people that are female, usually over the age of 60, and it's usually people that have narrow ducts. Now, how that was determined, I don't know. I'm sure that's just a supposition. There are two theories, and both of them have been shown to be effective. The iodine does seem to collect in the tears. The radioactive component of the iodine, iodine seems to collect in the tears, and then it passes through the tear system. But also, some of my colleagues in Ohio did a study where they looked at the actual tissue and stained it for certain transporters and found that there is a iodine transporter within the tear system. And so it probably at higher concentration pumps it into the tear system. This is probably one of the top 5 most common surgeries I perform, dacryocysto-rhinoscopy, or DCR. Basically, what you're doing is you're doing a bypass procedure between the eye and the nose, between the eye and the nose, bypassing the old tear duct. That's the whole idea of the procedure. It can be done lots of different ways. There's lots of different techniques. But basically, the techniques are broken up into going up through the nose and creating it, or doing it through an incision. 95% of my patients choose to have it done through an incision, believe it or not. There are pros and cons to both ways. The pro to doing it endoscopically or through the nose is that patients don't get an external scar. There's no incision, so there's no stitching. The con is that the success rate is right around 80%. So it's not a, in my opinion, a super successful procedure. The other way to do it is actually through that incision or externally, which has a success rate of 96%. And the way that I put my incision, and I'll show you post-operative patients, the scarring is typically not a problem. In fact, if I personally was having a tear duct surgery, I would have an external surgery. If you're in the East or West Coast, some patients will elect to have it endoscopically, because you can actually, or here, some younger patients will elect to have it endoscopically. And in that scenario, you can always go back and do an external one if it didn't work. So it isn't a huge trade-off. Again, those turbinates, this is my rough rendition, this is normally where it goes into the base of the nose. There's a middle turbinate, and between that base, inferior or bottom turbinate and middle turbinate, that's where you put your tear duct, new tear duct. And again, it's just a bypass procedure. So again, a CT scan that's cut like this, right eye, left eye, nose, brain. Bone should be continuous. This is just where the CT scan was to cut it through. This is a continuous bone out here, but you can see there's discontinuity in the bone right here, and that's a tear duct surgery that patient had. Because the idea is to create that new tear duct, and in order to do that, you have to remove a little bit of the non-perceptible bone that's around the eye. Internally, when you stick an endoscope in there, this is that middle turbinate right here. This is the septum of the nose. This is the middle turbinate, and then this is that new tear duct, and it's just showing those stents or tear duct tubes that I put in there that allow the tear duct to heal. This can actually be done, and I'd say over half the time it's done in an awake patient, believe it or not. So patients can, now if you do it externally, it's done with some sedation, but that can be done with people awake, and it's very well tolerated. Make a small incision, you remove a little bit of the bone. I use a drill, and it sounds kind of like going to the dentist. Doesn't hurt because we're able to numb this area up pretty well. And then close everything up with stitches. Most patients are swollen and bruised for at least a week. We take out the stitches a week after the procedure, and I take out tubes that I put, or stents, silicone stents, that I put in that tear duct to allow the new tear duct to heal around it. I take those out in the office about a month afterwards. Very straightforward. I'm going to show you some intraoperative photos just to show you how much exposure we're able to get. Through a small incision, sidewall of the nose, this is the inside of the nose, this is the tear duct. So I stick cottonoids, or I use cocaine, believe it or not, up in the nose. I use it on my patients, sorry. Just kidding. Use cocaine on my patients because it helps numb, but it also helps control any bleeding. I stick this up in in the patient's nose. I mark a small incision, and I make that small incision. We get down to the bone, open that tear duct, and use a drill that takes the bone that is right here off of there, and I leave the nose intact. So this is the inside of the nose. I make small incisions in the nose, I make small incisions in the tear duct, and then I suture everything together. And I put these little stents, or tear duct tubes, they're a little tough to see, but they're coming out of the nose here, in there. Again, I take those out about a month after the procedure. All these patients have had a tear duct surgery. So the patients that are concerned about scarring, I tell them in general, this is what most of my patients look like. And it's not me, it's just the way that the surgery is done. And so this person had a tear duct surgery on this side. This one had a tear duct surgery on this side. This one had a tear duct surgery on both sides. And this one had a tear duct surgery on this side. Occasionally, we'll actually do a tear duct surgery where we actually have to put a complete bypass in the whole system. And I use a glass tube. This glass tube is permanent. It is meant to be there forever. It is typically not the case in most of my patients that have thyroid cancer. But in this scenario, what we do, and this is common in my trauma patients, or common in patients that have been treated in stage with that Taxotere medicine. And in that scenario, I do a similar DCR to what we did, but instead of just putting those silicone tubes in there, I actually have to insert a permanent glass tube that goes directly into the tear duct. And it's meant to be permanent. It's not visible. People can't see it. My patients generally don't complain about any cosmetic troubles from it. But again, this is a CT scan showing the position of a tube around this left eye. So this is a CT scan that's cut like this. This is the right eye and the left eye and the nose, and this is that tube that's connecting there. Again, it's permanent. So tearing is more complex than just having a blockage of the tear duct. When I evaluate somebody for tearing, my goal is to determine the cause so that we can direct the treatment to that cause. Patients that have had treatment for any other type of cancer are a separate subset of my population and require a little bit more in-depth knowledge to know exactly where a blockage can be, or also requires the knowledge of how to treat people that have some of that reflexive dryness or tearing. Surgical therapy is very successful in my practice, and patients generally are happy. And while anybody that has had a growth anywhere, we always are a little bit conscious of making sure that there's no growth that is caused by their original cancer. And so in some patients, and I have seen this before, we open the tear duct, and it's a different story if you open that tear duct, and it's something that does not look normal. Really, that's all I got. These are my two daughters. This is Emma, who's 4, and this is Betsy. And I did a safety glass campaign for our hospital, and so this is my kids with safety glasses on. So I'm happy to field any questions that you guys have. Happy to talk about anything. Yes?
You said there's 4 of you who do this in the St. Louis area. Who are the other 3?
John Holds, Phil Custer, and then Gabriella Espinoza. So,
Are they all at BJC?
no. So Phil Custer is with me at WashU. Gabriella Espinoza is St. Louis University. And then John Holds is private practice, but also affiliated with St. Louis University and Mercy. And we're all friends, and we all get together, and we talk, and we meet every once in a while to just discuss interesting cases. In my field, there's 350 in the country, so right around that. And so it's a small field, and everybody gets along, and everybody's fine. So we're not competitive people. Yes?
I have the dry eyes I thought from that. My doctor, who's an ocular plastic surgeon in Pennsylvania, Dr. Carrasco,
Uh-huh.
suggested a trip repair.
Yes.
Okay, what is that?
So when the eyelid is out of position or has a looseness to it, occasionally in some patients that can actually precipitate or worsen dryness because the eyelid acts typically as a windshield wiper over the top of the eye. And if that eyelid is not firmly associated with the eye, then the eye will tear or be dry. And so what we typically do in many patients is we make, through small incisions in the outside corner of the eye, we do a horizontal tightening of the eyelid to try to get it to a more snug position and to get it in a better position against the eye.
Thank you.
Yeah, you're welcome. Yes?
Believe it or not, when I'm low on thyroid,
Uh-huh.
level is low, my eyes in the morning are full of tears.
Okay.
That is the first symptom that I feel
Interesting.
when I'm low.
Uh-huh.
But most of the time, I am balanced,
Okay.
so then I suffer from dry eye.
Right.
So I get chelation at least once a year.
Uh-huh.
Arthritis,
Uh-huh.
meibomian glands obstruction,
Uh-huh.
they call photophobia, you can call it, and I have it.
Yes.
I go to Boston Palmer,
Uh-huh.
sometimes like,
You're in a great place.
I know, but, like a month ago, Dr. C opened up my eyelids, and I guess I have to go back to him because it feels up again.
Okay.
So,
Dr. C is one of the world's famous, he's a world famous eye plastic surgeon, so.
and I go to Victor Perez,
Mm-hmm.
and next one.
Mm-hmm.
So, they have done all kinds of things, and I still get my dry eye.
Yes. I'll tell you that my experience with dry eyes and people that have significant dryness of their eyes is that there's not a cure. It's a battle, and it's something that there are good days, there are bad days. There are things that work sometimes of the year, things that don't work other times of the year. So in most patients, it's not like we can hand somebody a magic bullet. And so there are, as long as people are continuing to try new things, or you're up to trying new things, in most patients that you can find something that provides symptom relief in the majority of cases. So hopefully they're able to find you something good, because you're in great hands.
It's just that, it's a constant, I would have to devote my life just to the warm compresses and to this and that.
Yes.
But there are other things that you have to do in life.
Yes, of course. Yeah. That's actually a common thing that I hear from my patients as well. And I'm lucky. I don't have to put drops in my eyes. I don't wear glasses. I don't have contacts. So personally, I've been very blessed. So I think it's hard for us to stand in your shoes and know what you're going through. But I will tell you that as much trial and error as you're willing to allow will allow them and you to find the best treatment that fits within your lifestyle. Yeah. Yes?
So I've only been diagnosed and treated for about 9 months now.
Okay.
And one thing that's changed is my vision has drastically changed.
Mm-hmm.
And my eye doctor teaches at the University in Portland. I'm in Portland.
Okay.
And he won't re-prescribe I can't wear contacts anymore.
Right.
And now I'm using prescription.
Right.
I won't use that because I'm not balanced.
Right.
But my vision is getting so much worse.
Yes. And again, a common thing, because the cornea, or the front surface of the eye, about 2/3 of the light focusing power of the eye is in that cornea. And so if there's irregularities in it, people's vision will change, their glasses prescription will change, and they'll also notice progressive blurry. One of the reasons he or she is not willing to prescribe those glasses for you is that if you do, it's going to change. And so really the best, and I do the same thing, the most optimal thing to do is to have the best control before you get those glasses so that you're not wasting your money. Contacts are hard to wear in people that have significant dryness because the eye requires a certain amount of tears in order for those contacts to fit and in order for them to kind of sit on the surface of the eye. So,
It's just getting harder and harder. But like the other night, I had to drive up to the Sierra Nevadas, and I'm amazed on how bad my eyes were. I didn't realize.
I tell you, specifically before driving and different things, I tell my patients to make sure they put a drop in their eye 5 to 10 minutes before. And then that, in many cases, especially whenever you've got your vents going, you got heat or cold, I will tell you that colder or cooler environments are typically more drying. I also tell my patients to avoid the fan at night while they're sleeping, keep a humidifier in their house. Those are all things that seem to improve people's dryness. In addition, I do put people on fish oil, higher dose fish oil. Yeah, I know, I'm sure. I'm not telling you anything you don't know, but I do those things to try to improve people's symptoms. Yeah, blink a lot, yeah, or just, yeah, exactly. Yes?
You really raised my attention on a couple things, because you mentioned the turbinates and so forth. I've had 2 different nose surgeries before I went through the thyroid radioactive iodine. I had subturbinate surgery, I had a deviated septum surgery.
Mm-hmm.
I've also had LASIK surgery.
Oh, yeah.
So, and then the radioactive iodine. So
Right.
I have just like severe dry eye.
You kind of have like,
We're associated with the turbinates and it's possible there's an association with that.
yes, yeah, in some cases that's true. And it's not anything that, in all honesty, somebody that has a blockage of their tear duct and severe dryness is a hard patient to treat, because if I do something that opens their tear duct, it's like opening the drain in your sink. What happens to your fluid in your sink? It goes down. And so theoretically, doing anything that improves tear duct functioning in somebody that has severe dryness could make their tearing worse, or could make their dryness worse. But you kind of have every single reason to have dry or teary eyes.
And then on top of that, macular degeneration in one eye.
Yeah. And no offense, but you're a female, so it makes it more likely that your eyes are going to be dry too.
And then they put me on Restasis, which I've heard similar things to what
Yeah.
you're saying with that. And it just robs me. I mean, I don't,
It's amazingly expensive.
because of the expense,
Yes.
and I'm not sure I'm seeing the benefit.
If you don't use it religiously, you won't see the benefit.
Well, I was using it religiously.
Okay.
And then when I'm not, and I sort of
Do you notice it?
sustain
Right,
in between,
right.
and that helps.
Restasis itself does not actually lubricate the eye.
That's my feeling.
It's actually a very mild, semi-potent chemotherapy drug.
Well, that's my concern. What else does it cause?
It actually doesn't seem to have a lot of other side effects, but what it does is it treats inflammation in the eye. That inflammation is what can, in some patients, cause or worsen dryness. So I tell my patients, I give them a trial of Restasis if we're getting to that point. And I tell them, let's give it a couple months, and if you don't notice any benefit, let's stop it and see if you notice any worsening if you stop it. And then that's how I do it. In my practice, it works about 50% of the time.
Are there any questions you might suggest to arm somebody that I could go back and ask my eye doctor?
Yeah.
Look for, like, some of the stuff we went through in terms of testing, whether it's a blockage or whatever.
Right.
Is that something?
You know, I think the biggest things to be armed, and the most knowledgeable patients that I see, are the ones that come in and understand that dryness can actually cause tearing. Because that's where I spend the most amount of time trying to explain. As far as questions that you can ask, one of the questions that you can ask is, do you believe that my tear duct is blocked? And if they say no, then one of the things is, well, I mean, how do you know, or is there anything you can do to assess that? One of the common misconceptions in my practice whenever I irrigate those tear ducts is it's not opening anything. I'm not doing it to try to open your tear duct. I'm just doing it to test to see if it's open. And so in that scenario, I think that it's reasonable for somebody that is having a lot of tearing in their eye to ask, would you mind testing my tear duct? In many states, optometrists are not able to do that, but ophthalmologists are. In some states, optometrists are. It all depends on whatever state you're in. In Missouri, technically, optometrists are not legally allowed to. Some still do it, and I don't have a problem with that. But typically, it's an eye surgeon that has to do the irrigation of the tear duct. Yeah. Very good. Yes, ma'am.
My eye doctor never looked at my tear ducts. I do have a dry eye. He says I have blepharitis.
Blepharitis? Yeah, so the edge of the eyelid, right where the eyelashes are, there are pores where the eyelashes, where there are glands that produce a mucus component of the tears. And along those edges of the eyelid, which is kind of in the same ballpark as getting a sty, those tear glands, those oil, or I call them oil glands, mucus glands, can get inflamed and irritated. And if they get inflamed and irritated, then they don't produce their mucus very well, and then the eye can get dry because it doesn't have a mucus component trapping the water in the eye. And so in some cases with blepharitis, one thing you consider doing is baby shampoo scrubs. There are commercially available eyelid scrubs.
I'm using that tea tree oil scrub.
That's a great one. And then you can also do things like oral antibiotics, warm compresses, things like that. But again, very similar to dry eye, there's not a quick fix. It is something that is a management. You have to do things on a regular basis to keep tabs over it so that things don't get worse. But that's what blepharitis is. There's actually an entire textbook on blepharitis. There's about 8 or 9 different types of blepharitis, but the majority of what we're talking about is what you're saying. Okay, thank you.